I'm going to start off now by letting you know about our new teletriage model. And I touched on this last time we had a meeting in September. And I think we were just planning the live launch back then, but it is full up and running now at Melbourne Sexual Health Centre. So we are a booked appointment service now for the majority of people. We still do allow vulnerable people to walk in through our door, but that's about 5% of our clients. The rest, 95% of people, call and speak to a triage nurse on the phone now, and then if they're deemed appropriate for the service, they will be booked an appointment. And if we think they have something that can be managed really easily in the community, we would be referring them on, especially if we don't have capacity. So it's up and running. It started on December the 2nd. It's going really well at the moment. As you can imagine, with any big service change, there's always a period of adjustment. So there's a few little things that we're ironing out as we go along, and we're all learning together. But overall, I think it's working really well. We are definitely referring out a lot more people to our VSHN clinics. And I think it's really opening up people's minds to the fact that actually a GP clinic can be a great place to go and get sexual health care. And you can get excellent care out there in the community, and often at a place that's closer to where you live, and you're not having to manage coming into the city. And I've talked about before, often we have patients come into Melbourne Sexual Health and they'll tell me, I've travelled from Ballarat or Warrnambool today, or somewhere crazy. They're staying overnight in the city just to come into our service. But so this is really helping them to, find a place closer to them, which is excellent. I think we'll be referring more and more and more, especially through our real busy period, December, January, February. And I would really like to know if you're noticing a change in the demand for your service now that we are referring people out. So even if you can just send me a quick email just saying, yeah, we've noticed quite a significant amount of ship appointments are being booked up, that would be great. It's great for us to be aware of that. I actually think it's much easier now on the phone for us as teletriage nurses, because the patient's not there face to face in front of us. Sometimes you feel like you have to sort of say, yeah, well, they're here now, so we're going to see you, but it might be something really that's not a priority for us and could be well managed in the community. Now, when they're not face to face with you, they haven't made it to the clinic, they're just talking to you from the phone in their home, it's actually quite easy to refer them out to your services. So yeah, that's how it's going so far. And I will update you all again in March on how it's been through the summer period, but do let me know if you notice a change in the demand. The next thing I wanted to bring up was clinical placements at Melbourne Sexual Health Centre. As I've always said, I'm really open to anyone who wants to come in and sit in for clinical placement for any of our nurses in the GP practice clinics. You can come in and sit in for a morning or an afternoon. And recently I had Rose and Michaela from Kings Park come in to Melbourne Sexual Health and sit in, and it was really great to meet both of them and get to know them both a bit more and work with them. And I think they both really enjoyed their experience at Melbourne Sexual Health Centre. It's just sort of cements those sexual history taking skills. It's great. So we don't require the nurse to physically do anything when you're coming in for clinical placement. You're just sitting in there listening to the way that we ask people questions with sexual history taking, and the way that we use language, and sometimes that can be really helpful just to listen to someone asking those questions. So it was really great, and I was really excited to hear that at Kings Park they are managing a couple at the moment, a pregnant woman who has syphilis and her partner, her husband as well. So great job, guys, out there. It is, yeah, excellent to hear. Keep up the good work. Welcome, Lindy.
Oh.
How are you?
Yeah, good, thanks. Sorry, I'm a little bit late.
No problem at all. I'm
Nice
just
to
going
see
through.
everyone.
Yeah, nice to see you too. It's been a little while. Next thing I wanted, so clinical placements, if you want them, please just email me, let me know, and I can make time for that in 2026. The next thing to update you on is just the latest training and education that will be coming up. So Ashram is offering a lot of free and online training in sexual and reproductive health. I just had a quick look before, and they've got some contraception sessions coming up, some sessions on PrEP and trans and gender diverse healthcare. So get onto the Ashram website if you're interested in doing any free and online training. And obviously on our portal as well, we have an events tab. So you can click on there, and we will often have the links to any upcoming training that we think might be relevant for you as well. And then just a note as well, as it's always been, Sexual Health Victoria are still offering the 15% discount for our VSHN nurses who are interested in doing some specific courses with them. So if you are interested in doing some of those courses with Sexual Health Victoria, just be aware you are able to get a discount on those courses. The next thing to note, so I went to a nurses meeting yesterday with the counsellors that work at Melbourne Sexual Health, and they just said, surprisingly, because normally they're completely booked out, at the moment they have a lot of availability. So that's not only for our patients at Melbourne Sexual Health Centre, but it's for any of your patients at the VSHN clinics who would like to get some counselling around sexual health issues. And that could be ranging from relationship issues, sexuality concerns, diagnosis with an STI, how to tell a partner, sexual assault. Trying to think of other things. Often they will be able to spend time with people who have had either a diagnosis of HIV, or a lot of the times it's around herpes and people not feeling able to tell their partner or bring it up in a relationship, or what does this mean for them in the future. And often as nurses, we don't have the time to go through all of that in our consultation. So the counsellors are a great resource for you all to have. That's a free service, and they offer the service face-to-face or via the telephone. And the only thing your patient would have to do is just ring up and say, I'd like a counselling appointment. They'll speak to a nurse on the phone who might ask them a couple of questions, and then we can book them in. So it's really great to be aware of that service, especially because, seeing a counsellor or a psychologist, often there's an out-of-pocket fee for people and they just can't afford it. So, yeah, it's great. And they said, yeah, we want more patients. Please tell everyone. We really love to see people, or speak to them on the phone. So just be aware that's there and available now, which is good. My next point is about ViiV. So ViiV is the pharmaceutical company that is owns Cabenuva, which is the antiretroviral treatment for people living with HIV, the injectable treatment. And we touched on this at our last meeting. So ViiV have touched base with a lot of our VSHN clinics to come out and run some education either over a morning tea break or lunchtime with the staff around Cabenuva, and also how to inject it. So Cabenuva is injected into the ventrogluteal muscle, and I'm not sure if some of you use that site now to inject ceftriaxone and benzathine penicillin, but it's a bit different to the upper outer quarter that we used to do. It's more kind of around near the hip. and it takes a little bit of training, you know, just to get used to how to feel for the correct site. So Vive offers some education to come out, and they have like a dummy bottom that they bring out, and everyone has a turn giving the injection into the right spot. So we've had Yarram and Anglesey have both organised for Vive to come out to their clinic in February to run the training. And Lisa and I will be attending the Anglesey training, so that will be great to touch base with them. And then other clinics I know Lisa's been in touch with to organise some training further into 2026. So if you are interested in that, that would be great to also tick off. Great for your staff to do that, because even if you're not seeing anyone now who's having Cabenuva, you will be giving syphilis and gonorrhea treatments, and it is considered best practice to give it in the ventrogluteal muscle. So yeah, it's great for that as well. And also touching on that, giving injectable treatments into that muscle, Heidi will be chatting today as well about the future with injectable PrEP, which will be given in the same muscle as well. So I think that's sort of where we are moving to in the future. So it's great to have Vive out if you can. Hi, Neve. So that is Vive. And then the next thing I wanted to chat about is the portal. So hopefully you've all had the chance to get on and have a look at the portal recently. Lisa's pretty much been updating it all with all our different stuff. So I really would encourage you, if you haven't, to use it. It's great, got great resources on there. We've got all our STI toolboxes related to things like syphilis, MG, Mpox, partner BV treatment. So they're excellent, and especially if you're just sort of thinking, I don't know what I'm meant to be doing here, or what was the process for that, or protocol, everything's there for you at your fingertips. So get on and have a look. We also have all the recorded education for both doctors, nurses, and admin staff. So I know recently that a couple of the clinics have had some new reception staff come in and start. So this is a great space online that they can just get on and watch a quick 1 hour video around, you know, gender diversity or sexuality. Yeah, it's all there for them. So please, yeah, get on and have a look. Benzathine shortage, I just wanted to touch on that quickly. So I'm not sure what clinics still have the pre-filled syringes. We certainly don't at Melbourne Sexual Health Centre. We're currently using lentocillin, which you need to make up yourself with lignocaine. And I was doing that yesterday in the serology room at work, and I just found it takes a long time to sort of dissolve the medication, and the syringe actually blocked when I was giving a syphilis treatment to someone. So I ended up having to stab the person twice, the poor thing. But yeah, just be aware that the syringe can block quite easily with these different benzathine. So if that does happen and you do get a blockage, you just withdraw the syringe, change the needle over, and then you can put it back in again and finish giving the treatment. At Kings Park, do you still have the pre-filled syringes, or are you making them up? You've still got them.
We have few stocks. I always try to order as much as I can every monthly. So we have few in the fridge at the moment.
Great, that's
The
good.
pre-filled one.
Yeah, the pre-filled. Yeah. What about at Werribee?
Yeah, we have a couple of boxes at the moment.
Pre-filled?
Yeah, I
Yeah.
do the same. I just try to order this. Sometimes they tell me that, oh, it's low in stock or we don't have a stock, so
Yes.
I might just like keep something in the fridge.
Yes. Yeah.
My issue at the moment, the Mpox. Apparently, from the last conversation we had, I still have plenty, but then when I did another order, it's not there in one link anymore. So don't know who to follow up when are we gonna get it again from one link. Yeah.
Yeah, so I can see Lisa's putting her headphones on there because I know she has had a conversation with the person at the department who is in charge of stocking the MPOX. So I'll let her maybe speak. Oh, are you on mute? Yeah, you got
No,
it.
thanks,
Yeah.
Shan. No, I was just so I could actually hear properly.
Oh,
Sorry. But happy to add to that.
mm,
On the portal there is a email address to the manager of the Department of Health vaccine supply. He's aware of all you guys, and he is able to prioritize vaccines to services that need it most. So I would say you guys in Werribee, I'd reach out to him because you guys would probably be giving large numbers. Get in touch. You can only get it by 20 vaccines in a box, so you need to take the full box. They can't split, unfortunately. But yeah, a service like you guys would definitely be prioritised as a service. My understanding is the shortage will last until the end of the year. They're expecting a big shipment to arrive early 2026, which will free this up. But if you guys are needing it, reach out to him, and he's really helpful. I know Lindy spoke to him a week or so ago, and I hope that was a good experience, Lindy. You're on mute, Lindy.
All right. Yeah, he was really good, very helpful. Yeah. Yeah.
Yeah.
So yeah, we don't have any stock, but because you can only get the 20 at a time and there is such limited stock in Australia, I said I'll just contact him if I get into trouble and actually need a dose, because I don't want to take it away from other people. But yeah, he's saying by the end of December it should go back onto one link and we will be able to order. So just look out on your one link when we can back to normal again. Yeah.
mm,
So I'd probably stress any Metro GP partners reach out, because we've had that recent outbreak in Melbourne. So there's probably, that opportunistic, if you can give it to anyone, it's going to be worth having access to it. Thank you.
thanks, Lise. Neve, what about you down at Andrew Place? Do you have any trouble at the moment with your benzathine or Mpox vaccines?
No, we have Mpox, and we've had one of the councils get in touch with us about, because they can't get it anymore, and asked about our process. So we've talked about the process, and we're going to make it very simple so they can book in with the nurse and do it for people who we haven't seen by the doctor. Yeah. So if somebody just wants to come for Mpox, they can do that. Yeah, and they won't be out of pocket. They would be out of pocket if they see the GP for usual things or other things, but if they're just seeing the nurse and doing that, that's it. The other one, what's called the
benzathine.
Yeah, we ran out at Bundura, but we've got 2 sites, so we've split our stock, so we've got it in a no light container. So yeah, we've got stock at both sites. Yeah, and we have Mpox if anyone needs to send us somebody.
Great, excellent, great to hear. Thank you.
And we're getting through a lot of the Keftrixone.
Yes.
Yeah, and I've actually had a patient come for that who'd seen another doctor. So so it was just for the administration, and
Sure. Yeah. Oh, that's interesting, because they didn't do it at the clinic that the patient went to.
Yeah, I don't know why. Yeah.
Okay.
Yeah.
I was working in teletriage yesterday, and I had a couple of nurses ring up from just GP clinics in Melbourne with patients who needed syphilis treatment, and they couldn't get their hands on any benzathine, so they sent them to us. So yeah, I think it's probably quite common.
Yeah, right.
Thank you. The next thing I just wanted to mention is that we've been having a steady flow of patient feedback surveys coming through. So thanks to everyone who asks their patient or sends them a reminder to give us some feedback after their appointments. They have been really positive, and I just looked before I came on, and there's some really positive ones for Yarram, Grandview, and Andrew's place. So yeah, well done. And we recently put together our annual report for the Victorian Sexual Health Network, which has gone off to the Chief Health Officer at the department. And one of the features of the report is the really high satisfaction rate of our patients. So about 95% of patients would recommend someone else to return to a VSHN clinic for their sexual health care. So that's super high. So well done, everyone. It's really, really great effort. Welcome, Heidi. Thanks so much for coming. I've just got one quick last point before I will hand over to Heidi, who's going to run the education for today. It is visits for 2026. So Lisa and I would be really keen to come out to the GP practices and touch base in 2026. If you would like to have a lunchtime visit from us, we'd love to come out and see you. Usually what a lunchtime visit involves is us just coming out and having a chat, but also Mel Bessessa, who's the doctor that runs the education for the VSHN, she usually comes in on Zoom or online and runs a education session over lunch for the doctors and nurses. And it can be around any topic. Recently, we have gone out to a few clinics who've said they wanted her to go over BV partner treatments. Someone else wanted her to run through people wanting to get PrEP through telehealth. And yeah, there's been a few different ones, some on syphilis. So you can basically tailor what you want your education to be, and Mel will be online, and we can usually provide some nice lunch for you. And yeah, so have a think about whether you'd like us to come out in 2026 and get in touch with either myself or Lisa, and we can organise that because we would love to see you all. And so if anyone else wants to say anything, feel free to before I hand over to Heidi, who's from the Alfred, the HIV Prevention Service, and she's kindly agreed to come in today and run a session for us, just a refresher on PrEP, PEP, and also the future of injectable PrEP. So yeah, I might hand over to you, Heidi. Thanks so much.
No worries. Hello, lovely to see everybody. Good afternoon. Nearly said morning, but no. And lovely to see you as well, Chantal. Good to see you all. Some are familiar, some are not. If you're not familiar, it's a me problem. Don't worry about it. And I definitely wasn't finishing writing this presentation 4 minutes ago. So this is all extremely well prepared, I promise. So I've just put some things together on mostly around PrEP. I focus mostly on demand because I know that that one can really be a bit, I'm seeing some very emphatic head nods. It can be tricky for people to get their heads around. And I've got a nice little chunk about injectable PrEP, even though it is officially not really available here. Fingers crossed, all things will come to us in time if, you know, America doesn't catch fire and take us all down with it. You have to laugh because otherwise you cry. So I will just share my screen. No, nothing makes me feel more like an old person than trying to share my screen in an online meeting. Can I actually share my screen? Do I have that?
I feel like you should be able to, but I'm just having a look in the settings here to see.
There's a share button on the screen there.
There's fully a share button. Yeah, it wasn't a discrete one either. It was right there. Absolutely right there. All right, hold that one. Let us share. Okay, now there. Okay, do you have the presenter view or the notes view?
We have the presenter view.
Damn it. Okay, hang on.
Oh, sorry, like we don't
the
see your
display.
notes. Yes, sorry. Yeah.
Huzzah. All right. It's working. It's working. Somewhere I can
Okay.
hear my children laughing at me and they don't know why. They're nowhere near me. They're just like, oh, you're old. So, yes. So, prep nursing update, daily on demand and injectables, oh my. So, I would first just like to acknowledge the Bunurong, Bunurong and Wurundjeri Woiwurrung peoples of the Eastern Kulin Nation as traditional owners and custodians and pay my respects to their elders past, present and emerging. So, bit of a quick refresher on PrEP. I know that you probably all know this, but I will just rush over it initially. Bog standard PrEP is a combination of tenofovir disoproxil and emtricitabine. It is taken before sexual activity to reduce substantially the risk of HIV acquisition. It is currently the only option, oral PrEP is the only option available in Australia on the TGA and on the PBS. Important distinction there, because it being on the TGA or licensed by the TGA does not mean that it is available for people to actually physically get. And interestingly, the TGA only endorses oral daily PrEP. So the guidelines say something different, but the TGA is very much daily PrEP for everybody. And it reduces the risk of HIV transmission by approximately 99% when taken correctly. And it's currently only endorsed for sexual transmission, although it is recommended for people who inject drugs, for example, if other HIV transmission risks are present. In Australia, it's worth noting that we don't have a lot of HIV transmission through only injecting drug use. That is not the case with other parts of the world. As always, HIV is incredibly region specific, and there are other parts of the world where HIV transmission is very much more among injecting drug users. It's very much more between heterosexual couples. But in Australia, the vast majority of transmission does occur between men who have sex with men. So for people who inject drugs as their only blood-borne virus exposure risk, we try to focus more on making sure they have access to clean fits, not sharing their injecting equipment, and focusing more on those aspects. However, if they have other risks, if they are also someone who has sex with men, definitely we want them on PrEP because that is a very high risk cohort. If they have sex with people who are having sex with men and they inject drugs, again, there's a lot of nuance there. Ultimately, though, this is going to come up. Anybody who feels that they are at risk of HIV transmission can be prescribed PrEP. It is no longer, the guidelines have been updated. People don't need to meet this strict high risk requirement that they did initially. There was like a checkbox. You had to meet these, high risk categories in order to be sufficiently risky enough to qualify for PrEP. That's not the case anymore. So there we go. That is the quick refresher. Nothing is ever quite as quick as I mean it to be, though. So 2025, been a bit of a rough year for the HIV sector, I think we can all agree, which is a massive gross understatement. It's been awful. We won't go into it because I don't think we have the time or, frankly, the alcohol just to really get into the sheer unadulterated awfulness. And we're not going to know probably for several years the absolute devastating impact that slashing 90% of the global HIV funding that the US has done is going to have on the global HIV fight. We just don't know. And it's devastating, especially in light of some of the truly incredible breakthroughs that we've had that we're going to get to when we talk about injectable PrEP. And it's just at the moment that all of these this progress is being dismantled and wound back. Just recently we had World AIDS Day, and the administration forbade people from officially acknowledging it in the US. So it is just truly, truly a step back. So bear in mind that is going to be something that we will have to deal with, because like it or not, what happens in the US does affect us on both a global and a local stage. Case in point, the first Australian PrEP guidelines were actually based in part on the CDC's PrEP statement, like PrEP guidelines. So yes, they were written by Edwina Wright, Professor Edwina Wright, but initially in 2015, before Truvada was licensed in Australia, but they were definitely influenced by the US guidelines, but localized to the Australian context. So we have a new set of guidelines. Some of you may have joined the PEP update that we did recently with lovely Dr. Mel Bessessa and Jude Armishaw. Anyone attend that one? Or absolutely fine if you didn't. I know that it has been recorded. I would recommend having a look at that one. It's only about 40 minutes, and it does have some really useful information in there, because while PEP and PrEP are not the same thing, they do go very neatly hand in hand. So the goal of the guidelines, and what they've really done, is streamlined things to reduce confusion, because again, you used to have to meet these very specific high risk requirements in order for people to say, well, yes, you can have PrEP. That's not the case now. If people feel that they are at risk within reason, they can be prescribed PrEP, and as long as they have good renal function. Again, renal function is also not a disqualifier. If somebody has particularly bad kidney function, they can be prescribed Descovy, which is a different formulation of tenofovir, and then have that imported from overseas. That is a bit more niche and specific. More information can be, like, you can reach out to us for more information about that, or wonderful Chantal and Lisa can absolutely, have a chat to you about that more specifically. But bear in mind, there is no real barrier to PrEP access for anybody besides outright anaphylaxis or, complete inability to tolerate. And it has also expanded the on-demand recommendations. Previously, the recommendations were just for men who have sex with men. Cisgender men who have sex with men can have PrEP on demand, and that was it. We knew that it was likely just as effective in the population of men who have sex with women, but we didn't have the data. Then they did some studies in sub-Saharan Africa and found that it was just as effective among men who have sex with women. I could get into a whole bit of information that I did around foreskin studies and tissue, like drug penetration into different tissues. It's not really relevant, and it will only get confusing, and you only want to have to read / hear foreskin slice segments so many times before you're like, what am I actually reading? But suffice it to say, PrEP drug targets, it reaches different target tissues at different concentrations in different speeds. So that's part of the confusion around PrEP on demand and why it is currently not recommended for everybody. So leading nicely into the fact that there are still restrictions around who is recommended to have PrEP on demand. Currently, cisgender women and transgender folks do have some restrictions. So basically, cisgender men, no matter who they're having sex with, can have PrEP on demand. Trans and gender diverse folk who are assigned male at birth and not taking any gender affirming hormone therapy can have PrEP on demand. So if they are trans women who have socially transitioned but not medically transitioned, they can have PrEP on demand. If they are taking estradiol, it is not currently recommended that they take PrEP on demand. However, if you have any, I don't know if you can hear that, but the announcements are really loud in my office. If you have if you have cis women, or if you have trans folk who are assigned female at birth, it is not recommended that they have PrEP on demand. However, if they have no vaginal activity, if you have trans men who have no receptive vaginal activity, if they are only having anal sex, receptive anal sex, they can have PrEP on demand. That is the current recommendation in the PrEP guidelines. Again, the TGA says daily PrEP for everybody, but our guidelines have a different recommendation. So yes, the guidelines also, and the TGA has approved TAF, the different formulation of tenofovir that is in Descovy, which is used for HIV treatment, for those who wish to use it, which includes under 18, which is a different kettle of fish we won't get into, but bear in mind they are a cohort there. But again, that is for self-importing because it is wildly expensive and there are no generics of Descovy. It's not actually that difficult to do, but you do have to import it from somewhere like Green Cross Pharmacy. So there's additional steps. It's not as simple as taking script, going to pharmacy, unless you feel like paying thousands of dollars to access your PrEP. So the reason I'm belaboring all of these things is because every country's guidelines are different. And because we used to hew much closer to the US guidelines, we're not looking at the US guidelines or the CDC website for roughly the next minimum 3 years. If you look at the US CDC website right now, it's got some very transphobic language on there, and basically some of their PrEP websites are only up there, and it says at the top, literally because a court order has made them. And the sound I made as I read that, it was deeply distressing. So do yourself a favor, they're also just systematically dismantling and undoing all of this work behind the scenes of data. There's just no data coming into or out of the CDC. So we just can't trust anything there at the moment. Even things that have been there for decades, we don't know. And that goes for the HIV treatment guidelines as well. So we're having to look to other parts of the world and other guidelines. Why this is relevant is the UK guidelines, the BASH guidelines, are very different to the Australian guidelines. The UK guidelines say on demand for everybody. So yes, this is why I have been talking about this and slightly belaboring it, because we just don't have the research to be able to back that up with the degree of confidence that we want to be able to. I would love to say yes, because it's entirely possible that it is safe. It's entirely possible that it is. The trouble is there is an absolute void of adequate data around trans and gender diverse and cisgender women when it comes to PrEP and, well, I mean, all trans and gender diverse folk. There's just not enough research and inclusivity there. And it is really felt when it comes to this kind of context. So it may be fine, but we don't have that reflected in the data. So out of an abundance of caution, our guidelines say, this is who gets on demand. Everybody else, we do not recommend it. So yes. Are there any questions from that? Because I know it's a bit of a funny thing. You'd think that you'd be able to trust UK guidelines, and I'm not saying you can't trust them. I'm just saying that they have their own reason for it, but they also have their own very different context. They have their own PEP guidelines too. And again, HIV is a very region-specific social situation. It's the same virus, broadly speaking, besides HIV-1, HIV-2, and various drug resistances. Resistance, it's a word, it's fine. But the different social context is very different. So our guidelines reflect that in part, But again, we don't want to get into the different facets of the NHS because, again, time, alcohol, all of these things. So if you have people coming to you from overseas and saying, but I've been taking this regimen all this time and I'm fine. Yep, that's fine. This is what our guidelines say. They're up for review in 2027. Who knows what data we'll have by then? There is a real push, and there has been for the last few years, for more inclusive data. Nothing about us without us is a big one for trans and gender diverse folk. And hopefully we will start to see some really good actual indicative data that will show that, yes, this is fine, or more than fine, non-inferior even. But right now, we just don't have the data to enable us to say, yeah, absolutely, 211 for everyone, or 21111, as they do in some parts of the UK. So yes, there you go. It's a lot of info for one slide, I know. And now I thought, after all that talking, because a picture is worth 1,000 words, here are some good graphics, because I find there is nothing quite as helpful as a graphic when it comes to explaining the on-demand method. So I've always loved this one on the left from the Prep Access Now website. The only reason I'm including a separate one from there is because they've insisted on having this guide is only recommended for cisgender men who have sex with men. And that is not actually the case anymore. And I always like that they use eggplant emojis to indicate when it's safe to have sex. And the one on the right is actually, you can set on the PAN website to have it either horizontal or optimized for phone screens. So this one is actually a phone screen optimized one. So if you are trying to explain to someone, on demand, especially someone for whom English is not their first language, a graphic is so much easier to get that information across. And honestly, people for whom English is their first language will struggle to get their head around on demand. We all struggle. It's always 9 o'clock in the morning somewhere, and we're all struggling. And it can get even more delightfully complicated. So again, I just thought a few different options. I've included sources of where I got them if they weren't included in there. These are both UK sources. The first two were from Australian sources. And yeah, all showing slightly different ways of saying the same thing, because people will have different ways of integrating that information. I'm very happy to send these slides across to Chantal so that they can be sent around to all of you, because yeah, you can also just Google Prep on Demand graphic and filter through, but bear in mind you do have to search through a lot to find one that is accurate and legible. Because sometimes it's like, wait, what, when do I take it? Sometimes it says you take the subsequent doses 24 hours after sex, and it's like, no, it's after the dose, not the sex. You take your double dose, wait at least 2 hours before you have sex, and then you take your single dose at the same time as your medication, not the sex. So yes, it's always room to make mistakes with on demand. Genuinely, daily is so much easier. But the important thing is people have options and they have choices. That's one thing that people have really expressed through a lot of different research. The main thing they want is, just like birth control and contraception, they want options, and people do tend to be more adherent and have greater acceptance and tolerability of whatever PrEP or contraceptive option when they have choices. So yeah, that's the takeaway as always. So injectable PrEP, what we're all more excited about. So cabotegravir is the one you would probably know the most about, because that one has been licensed by the TGA. It's a 2-monthly intramuscular injection with an oral tablet lead-in. It's an integrase strand transfer inhibitor. You are not going to be tested on this, don't worry about it. And the trials showed that it was not just non-inferior to oral PrEP, it was superior at preventing HIV infection. Breakthrough infections can occur. It has a very long tail. So if somebody misses or they cease their PrEP injections, but they continue to have potential exposures, they can still acquire HIV. It is also not 100% effective. Very few things are 100% effective. So there is always going to be that risk. That is why condoms are still really useful, and hey, they help prevent other STIs. So it is licensed by the TGA for both prevention and treatment. In treatment, it's combined with rilpivirine and called Cabenuva. For PrEP, it's called Apretude, which I don't love the name, but they didn't ask me before they licensed it. It's not currently approved by the PBS. They couldn't come to an agreement because it was too expensive. However, and yeah, that's not likely to change before generics become available in 2027. So watch this space. But if you have a patient or if you have someone in your practice who you think would really benefit from Apretude, you can apply for compassionate access. There, I think, are 100 spots available for a variety of different reasons. I've actually put one of my patients up for it and just going through that process there. So yeah, definitely a good idea. I also liked this picture I found from like a Hong Kong website, and they're making it clear PrEP is not this sort of arcane, you know, abstract clinical thing. People are having sex. This is why people are taking these measures. It's they want to have sex. So, you know, they're not burying the lead when in this clinic. This is a sexual enhancement. So, you know, I kind of like that positive display. So yes, there is that. The far more exciting one is lenacapavir, which I think is, yeah, Yes to Go is its name for PrEP, is the 6-monthly subcutaneous injection. It is a capsid inhibitor. So this is a first-in-class, I think, a novel class of antiretroviral. So it doesn't just work at one point in the HIV life cycle, it degrades the capsid at multiple stages. So all of the previous options work at one, all of them work at one particular point in the life cycle, whereas lenacapavir just degrades the virus through multiple stages. It is incredibly effective. It's currently approved, licensed by the TGA for treatment of multi-drug resistant HIV, along with other antivirals, and is currently being studied across multiple settings around the world in the PURPOSE studies. PURPOSE 1 and 2 were both finished early because they were wildly successful. In the PURPOSE 1 study, there were 100% like 0 infections in girls and young women. And in the PURPOSE 2, which was in cisgender men and trans and gender diverse folks, they were 96% effective in reducing HIV infections. So again, this is wildly effective. And they're currently recruiting / underway in the above groups, as well as cisgender women and people who inject drugs. Because again, those are groups that we don't have as much data around these, you know, for these more specific types of exposures. So it's currently under assessment, like it's being reviewed by the TGA as like for prevention. And we're just waiting to see what happens. It has been approved by the FDA. So we don't have a vaccine against HIV, but this is kind of the closest we've got. If people can have a 6-monthly injection, that's pretty amazing. And it's subcutaneous. It's not without issues. There have been some pretty unpleasant injection site issues. It's not as simple as, you know, insulin or Clexane. You know, it does have to be administered quite carefully, but it is still incredibly promising. So yeah, this is the one that we're most excited about, and they are working really hard to get generics through, learning from the problems around cabotegravir in licensing and everything else to make sure that generics happen. And there will hopefully be generics coming through for lenacapavir by 2026, 2027, because it's really crucial that this does get to places that have much higher prevalence and transmission of HIV, especially in these groups that are no longer getting aid money and assistance. There's also things like the monthly, like once a month pill, which is MK8527 that's currently being studied. They're also looking at a once a week pill, which is also pretty interesting. There's things like combined oral contraceptive and PrEP, and like the dapivirine vaginal ring that is currently in use in sub-Saharan Africa, that they are maybe looking at licensing in the UK, and they're looking at combining that. There's a 1 month self-insert, again, set and forget. And they're looking at a 3 month, which is even more effective, and looking at combining that with birth control, which is also, yeah, again, multiple options, because 53% of people worldwide living with HIV are women and young girls. So, you know, bears repeating, since that's not the case of the people that we see here. One last thing before we run out of time is PEP on the Line is a new service that we are doing, the HIV prevention service based at the Alfred, to deliver PEP via telehealth. So it is available just on the 1-800 number that people have, which is open Monday to Friday, 9 to 5. And it's not formally launched, but it's soft launched. And it's for people who need PEP, not complicated. So if someone has maybe had a sexual assault or something like that, or if they are quite complex, we will triage them out to possibly one of your sites. They do need to have Medicare because it's an e-script, and our system is stupid and will not allow us to send an e-script if someone doesn't have a Medicare card. But yeah, basically it is to make it easier for people to access PEP in a timely fashion without having to go to ED or to go to a GP clinic, because we know there is a crisis in primary care. I don't have to tell any of you that. So that's that. Thank you.
Amazing. Thank you so much, Heidi.
No worries. Sorry for ranting in there a bit.
No,
It's kind of hard not to.
no. That was so interesting. I'm not sure if anyone has any questions for Heidi.
I was just more a comment. Yeah, that's just shocking about the US. Like, I'd kind of briefly heard about it, but I suppose when we, you know, hear from yourselves, you kind of work in the area more, so you're just like, God, that's so awful.
It's
Funding
grim.
stuff, yeah, really bad.
Yeah.
Yeah.
It was already a really rough situation for people living with HIV or at risk of HIV in the US,
Right.
just due to the sheer socioeconomic gap,
Right.
and the effect of race and
Marginalizing them.
yeah, everything. Like African American gay men have a 50% chance of acquiring HIV in their lifetime in the US before all of this, which is just an outrageous statistic. African American women are also far more likely to acquire HIV in their lifetime compared to white women.
Oh yeah, sorry, I'm just gonna have to go. Excuse me.
Oh, no worries.
That's okay. Sorry about that. But thank you very much, everyone. Okay. Thanks, Chantal.
Steve.
Thanks.
Bye.
Thanks, Steve.
There's a question?
Yes.
Yes. Can you hear me?
Hi. Yes, I
Yes.
can.
Yes. Heidi, what's your thoughts about those people jumping from daily to daily? I mean, daily to on demand and then back to daily again and on demand. Where do you draw the line that, okay, this is much better because
Yeah.
so this, and this is much better because this.
So that's the thing about PrEP. It's flexible.
Mhm.
So some people will start on demand. So they take their 2 pills, they wait 2 hours, and then they take it for 2 days after the last time they have sex. And then they just never stop having sex. So they just continue to take PrEP. And that's completely fine. Other people will take it daily, even though they have sex once a month, because they're like, I just don't want to think about it. I take my PrEP every day. I don't want to get out of the habit. As long as they have no renal impairment, no other concerns, that's also completely fine. It's genuinely, as long as they're taking it correctly, they can go back and forth between the two. So it's good to talk about safe starting and safe stopping when they start taking PrEP, and to touch base every now and then and make sure they're taking it, that they know that. So we like to double check with people. So, like, can you tell me how you take your PrEP? When you take it on demand, what does that look like for you? Because that's when you find out, oh, I took one pill and I waited 2 hours, and it was like, oh, baby boy, no. So it's 2 pills and wait 2 hours. It's not take 1 pill and wait 2 hours, or take 2 pills and wait 1 hour. If you forget to take your PrEP at least 2 hours, your 2 pills at least 2 hours beforehand, there's no point taking 2 pills after you have sex. Like, there's just not. It's also really important to remind people, or to let them know, that PrEP and PEP are the same drugs. So if they forget to take their PrEP on demand, they can just take their PrEP as PEP once a day for 28 days. They don't have to come in to make an appointment. They don't have to go sit in emergency, because they've got their PEP in their hot little hands. So to just have those conversations and make them part of the consult, make them part of the pathology, and just get them to repeat it back to you, to have them say to you, like, what do you understand to be the correct protocol? Like, tell me how you take this. Because I think, sometimes you say to someone, so you understand? And they're like, yes, I do. And no, they don't. And they may not feel comfortable in saying, I have no clue what's going on, because you might take the PrEP away.
Yeah.
So, just being gently like, tell me what you understand of what's just happened here. And that's one reason why I like using the graphics. Sometimes you can see when the light has switched, and they're like, oh. There's also apps that people can use, like PrEP apps that are free in like the App Store and on Google Apps, whatever that one's called, that give people reminders for when it's time to take their PrEP or time to get tested and whatnot. They can also just use a dosette box, like go old school and have like, we got given some of these recently, and they're cute.
Oh, they are.
I may or may not have one of these at home for my meds, because, chronic illness, but make it rainbow. Especially if you have someone who's really anxious, and then you don't want them pretending for PEP and going, no, but I've forgotten to take, I haven't taken my PrEP, and then I had sex and give me dolutegravir. Or they mark off on an app that they've taken their PrEP, and just use the dosette box. Use the dosette box and save yourself some time and some stress, rather than remembering to take the pill and then remembering to mark off in the app. Who has that much memory? I mean, clearly not me. Any other questions?
Thanks for that, Heidi.
You're very welcome.
I just had one question for you, Heidi. I wondered, you said you're in soft launch of the telehealth pet.
Yes.
I wondered when that was going live fully.
Look, it's available now.
Okay.
So yeah, it's more a case of, oh, do we have someone who's appropriate for this? Since Jude has her nurse practitioner, she can do our prescribing. So yeah, it means that since Melbourne Sexual Health, I know that you have your triage, like your tele-triage, and yeah, it shouldn't really have too much of an effect on that necessarily, but hopefully it'll take some of the pressure off, especially for those people who are pretty straightforward, but don't need, or it sucks that we can't do it for people without Medicare at this point, because again, that's the biggest struggle. And that's the vast majority of our PrEP patients are people who don't have Medicare. So that's always what we're looking for. Yeah, I actually didn't say that. Yeah, I usually say, oh, we also do the Prep Me clinic for people who don't have access to Medicare. So just pretend I said that like half an hour ago.
Yeah, it's fine.
So yeah.
And so the patient would get an e-script and then also a path form, would they?
So we will email them a path form.
Yep.
And we follow up with them. If they need dolutegravir, for example, it's not a barrier for that because we have the partner pharmacies that they can go to, so they don't have to pay the $600 for dolutegravir. And yeah, it is really just we set them up in our Alfred system. We do a telehealth. We can do a telephone call if they don't want a video call for some reason. And yeah, just do everything that way. Email them the path slip, send them the e-script, and then follow up with them and arrange a 6-week follow-up to make sure they get their follow-up testing done. A bit of a return to the early days of the PEP service, which we just celebrated the 20-year anniversary of last week. So yeah, 20 years of the Victorian PEP service, because 2005 was 20 years ago if you wanted to feel sad for just a moment. Because we all did, and I need to share that. Misery loves company, and if that's not the subtitle of my presentation today, I don't know what is.
Great, thank you.
Yeah, no, sorry. Merry Christmas. Should have done this in like paper hats. I'm loving the Christmas tree that you've got on.
I know. I said, well, Janelle I just found out she's like really good at textiles, and she's made all these beautiful Christmas tops for the staff at Werribee.
Fantastic. The only thing I could have done is maybe put on a tiny sombrero. It only just occurred to me. I have a tiny crocheted, I took it off a tiny crocheted penis cactus, but yeah, it's on my desk. It doesn't make a very good hat.
Set box.
Well, yeah, no.
Oh, thank you so much, Heidi. Thanks for coming in, and thanks everyone
for having me.
Thanks everyone for joining today for the last Nurse Community of Practice meeting. I will send through some minutes this afternoon, and of course this is recorded, so it will go onto the portal, so everyone who isn't able to make it today can watch it. And Heidi, if it's okay, can you send me through your slides?
Yes.
And I'll make them available as well.
Will do. Thanks so much, everyone. Have a lovely one. Happy holidays.
Thanks, everyone. Happy holidays.